75% of electrothermal bowel injuries go undetected during surgery. Hey, my name is Wendy, the Surgeon's Roadie, and this is part 3 of my series on electrosurgery, where we discuss safety in minimally invasive surgery. How do you like the uniform? So ridiculous. In the operating room, we don't get fixed. I'm just trying something new, okay? Give me your feedback. Maybe don't be honest. Minimally invasive surgery in this context is laparoscopy. I also didn't mean to scare you guys with that 75%. Actually, the incidence of electrothermal injury in the operating room is relatively small, according to a meta-analysis in 2006 that said 0.13%. I'm sure that a lot of burns go underreported, so that's just something to keep in mind. Laparoscopy is when we make small incisions in your abdomen and we inflate it with CO2 so we can see everything in there, your guts. Now, there's 2 different types of electrothermal injuries in laparoscopic surgery, and one is called direct, and the other one is called indirect. Examples of direct, pretty obvious, right? Misidentification of anatomy and overcooking it. I said in the last video that we're not cooking up charcoal briquettes, but you know, some surgeons really like to release the flamethrower in there. I don't know. Probably helps with their anxiety. We're going to focus mostly on indirect forms of electrothermal injury, chief among them being an insulation breakdown of your laparoscopic instrument. Inspect your instruments for cracks, breaks, worn spots, weaknesses every single time. Why does this matter? If there's a break in insulation, electrical current can escape through that defect and instantaneously damage non-targeted tissue. The surgeon won't see it, and you won't see it because it's out of the surgical field of view, and you may not even catch it on the recon because it's just difficult to see, because we know burns get worse over time. Literature says it takes about 10 days for that to progress into sepsis, the bowel injury to progress into sepsis, increased mortality, so check your instruments every single time. Direct coupling. When activated, electrocautery makes direct physical contact with another metal instrument, like the laparoscope. Electrical current transfers directly to that metal instrument, and if that instrument is touching tissue, you get an unintended burn. Did you guys just see my face flickering? That's the built-in retouch filter on TikTok. I forgot to disable it. I'm over 40, so it was in a fight for its life to cover up them wrinkles. But anyway, back to direct coupling. To prevent this, the surgeon should only activate the electrocautery when the tip is in their field of vision. Number 3 is capacitive coupling. That's actually pretty cool. Nikola Tesla used it in 1899 when he built a big-ass coil right where I'm standing inside of a big experiment barn, and he transmitted so much electricity that he was able to light up every light bulb in town wirelessly. Nikola Tesla. Here's Tesla's coil in a building made of Lincoln Logs. Do you see this building right here? That's actually this building, but there's a big no trespassing sign, so now I gotta get out of here. Capacitive coupling happens without any direct contact. The electrical current running through the activated insulated instrument creates this electromagnetic field, and then electricity is transferred to adjacent conductive material. It's actually really rare in laparoscopic surgery these days because we don't use hybrid trocars anymore that are part plastic and part metal. I just really wanted to show you guys something cool. And you know, Tesla's cool, except for that whole, when he fell in love with a pigeon, that was kind of weird. But I mean, other than that, like, was that so unexpected? Antenna coupling is likely not in your textbook. It's a form of capacitive coupling, and although there's definitely a risk for it in the operating room, I genuinely haven't seen it. What you want to do is avoid grouping your monopolar and your bipolar cord with your camera, especially you guys on Da Vinci robots. You know how we link them together and we put them in the Irby machine, or we wrap a stylet around them for convenience. You don't want to do that because you could accidentally turn your laparoscope into an electrically charged instrument when you activate that electrocautery. I personally have never grouped my camera and light cord with the electrocautery wires, but just because I haven't done it sure as heck doesn't mean that it hasn't been done. Good here? Because let's talk about active electrode monitoring. AEM is designed to detect and capture stray energy before it causes harm to the patient. They make AEM adapters for laparoscopic instruments, and I want to know, does anybody know? Does anybody know who owns the patent for active electrode monitoring devices? If somebody gets this, I'm going to be so impressed. It's Incision. It's that little adapter, possibly that's at your hospital. You might have it in your operating room hanging off the side of your generator. And it's a fail-safe technology for coupling and insulation. I haven't seen it in practice a whole lot. Anyway, why use a safety device when we're channeling Tesla? You know what I mean? Anyway, all right, see you next time.